So we are at a time in history where effective systemic therapy is available for renal cell carcinoma. We know that it's a chemo-resistant tumor, and in a way it is radio-resistant as well. The standard of practice used to be cytoreductive nephrectomy, because that's the only thing available, the scalpel of the surgeon for advanced renal cancer. We need to see whether it's still valid. Well, the incidence of cancer and mortality statistics are interesting because if you see it, even in the United States, there are about 80,000 patients who are diagnosed in the year 2022 with renal cell carcinoma, and about 14,000 died of this condition. And this is something that we've been seeing for a long time, that the incidence is going up, the mortality has remained static, although we have been diagnosing kidney cancer at a much earlier stage now than what we used to maybe a few decades back. If you look at the statistics of our part of the world, i.e. the Southeastern Asia and South Central Asia, between 12,000 to 25,000 cases, underscoring the fact that these patients, the statistics and the surveillance data is not as strong as in the West. A lot of people are dying from cancer as well. 4,000 out of 12,000 and 25, over 9,500 out of 28,500 so cases in South Central Asia. So in the last century, we've been diagnosing cancer with what is used to be called as a Gravit's triad, which means a palpable mass, hematuria, and pain in the flank. Hardly any patient is now diagnosed with this condition. The majority are diagnosed on imaging, which is done for some other reason. So if you look at the data from the United States, we see that about 17% patients at diagnosis still have metastatic disease. And out of those who have been treated for localized cancer or on active surveillance for localized cancer, about 1/3 can develop metastatic cancer. So what can be done for this condition? Well, about over 20 years back, these were the 3 landmark studies by Gerhard Mickisch, Robert Flanagan, and Lara. And this is the so-called cytokine period. And in this cytokine period, we had some response because obviously there's nothing that can be used as a systemic therapy. We moved and taken a real leap into future and towards progress when targeted therapy was introduced, thanks to our understanding of the VHL gene and its mutation and its impact on development of the renal cell carcinoma. The Carmena and SOTIME trial have been the landmark studies. But now we have moved even further with the introduction of the immune checkpoint inhibitors or immune oncology. Quite a few landmark trials have already been reported: the Checkmate 214, Keynote 426, Javelin, Checkmate 025, the IM Motion, Checkmate 9ER. And there are some in the pipeline looking at the need and indication for cytoreductive nephrectomy in the era of immuno-oncology. The CytoKick trial, Nordic Sun, and the Prof trial. And I'll briefly discuss the Prof trials protocol in the coming slides. So when we say advanced cancer, we actually have not a clear definition. So we basically mean cancers which are advanced because of the stage of the disease, or they are aggressive because of the typical histology, Patients with metastatic cancer are invariably advanced cancers, and these metastases could be metachronous, which is relatively less aggressive than synchronous metastases. So patients who present with synchronous metastases have a shorter overall survival, even with the utilization of the contemporary immuno-oncology. In the Checkmate 214, the median survival of the group presenting with synchronous metastases was less than 2 years compared to 4 years for all patients, all other patients in the study. So synchronous metastases basically is a bad omen. What have been the landmark trials and what have we understood about the need of cytoreductive nephrectomy from these slides? The SWOG 8949 study that randomized patients with synchronous metastasis RCC with upfront nephrectomy followed by interferon versus systemic therapy. And this trial basically showed that cytoreductive nephrectomy has role. Similarly, EORTC 30947 by Gerhard-Mikisch showed a statistically significant improvement in overall survival in patients who received cytoreductive nephrectomy. Well, the putative mechanisms which were put forth were that cytoreductive nephrectomy helped eradicate some of the resistant clone of disease and enabled improved outcome to systemic therapy. Then came the Carmina and the SOTIME trial. The Carmina trial looking at the use of this systemic therapy with sunitinib, and they've shown that upfront cytoreductive nephrectomy probably is not really indicated, although there are issues with those trials, but still it's one of the landmark study that we have at the moment. The surgery time trial by Bex and colleague reported in Journal of American Medical Association Oncology 3-4 years back really looked at the time of cytoreductive nephrectomy. Should it be done up front or should it be done delayed after systemic therapy? And the result was indicating that cytoreductive nephrectomy can be delayed in significant proportion of patients. Well, we have moved from the systemic therapy using the VEGF, and now we are entering into the era of, or we have already entered into the era of immuno-oncology. The Checkmate 9ER reported by Motzer some years back enrolled the highest portion of patients without nephrectomy, and it was about 30%. Keynote 426 had only 17% patients who had who didn't have nephrectomy. Javelin had 13%. Checkmate 214, gained by Motzer in New England Journal of Medicine, 2018 had about 22%, and Clear trial had 20% who did not undergo nephrectomy. So if you look at the modern era of immuno-oncology, see that all these trials still have significant proportion of patients who had cytoreductive nephrectomy. So it's incorrect to believe that ICI will eliminate the need for cytoreductive nephrectomy. So what's a rationale for cytoreductive nephrectomy in advanced RCC? Delayed cytoreductive nephrectomy after immunotherapy may be beneficial compared to immunotherapy alone, and this is coming from some of the leading trials that have been reported with ICI. The surgery time trial, or the SOTIME trial, showed overall survival significantly longer in patients undergoing delayed nephrectomy. So the SOTIME trial really posed the need for upfront nephrectomy in their cohort of patients, and we know that there are some issues in terms of accrual in that study, and the number is smaller. Use of ICI prior to cytoreductive can generate a stronger immune response than upfront cytoreductive nephrectomy followed by immunotherapy. And the rationale of this is important to understand, that use of systemic ICI is going to create a much broader base immune response than using ICI after the nephrectomy, because you've taken a lot of antigen load away. So the kind of response that would develop is less if it is given after the cytoreductive nephrectomy. So surgical resection decreases the PD-L1 expression on tumor, and that probably is the rationale for using delayed nephrectomy with ICI. The initial cytoreduction has the effect of surgically reducing the mutational load and decreasing the diversity of private mutation. And after the immune stimulation has occurred, cytoreductive can remove a source of potential metastasis and immune suppression. So I think the combination and the timing is becoming more and more clear with these newer trials. What about the safety of cytoreductive nephrectomy following ICI? So, I mean, after receiving ICI, are the patients less likely to have, more likely to have complications of surgery? Well, so time trial using sunitinib, the Prosper trial using nivolumab, neoadjuvant ICI by Karam and colleague using zitinib, and a prospective pilot trial of pre-surgical ICI by Grimm and colleague in European Urology in 2019 using ipilimumab, have all shown that it does not. So nephrectomy can easily be done after the patient has received immune checkpoint inhibition. These are some of the upcoming trials, and they are mostly recruiting at the time of this publication, using various combination of ICI, so IO and IO versus IO and VEGF inhibition. So again, cytoreductive nephrectomy's role will become much more clear when some of these trials are reported. The Probe trial is again one of the upcoming trial. The protocol of the Probe trial was recently reported in, and the details were shared. The study hypothesis is cytoreductive nephrectomy will improve overall survival in synchronous metastatic RCC when surgery is performed after starting systemic immune checkpoint-based combination therapy. A potential mechanism leading to improved survival is that the broader antigen spread and the higher neoantigen load enabled by the primary tumor enhancing the efficacy of the immune therapy. The rationale of cytoreductive nephrectomy after initial systemic therapy will help select patient subset who are most likely to benefit, potentially enable eradication of immune-resistant clones within the primary tumor. So cytoreductive nephrectomy in metastatic non-clear cell carcinoma, so we have mostly been focusing on clear cell. Well, exclusion of non-clear cell carcinoma is quite evident from some of the leading trials, the SWOG 8949, EORTC by Gerhard, Mikesh, Carmina, and Sotime. So we need to look at some of the smaller studies looking at the impact of cytoreductive nephrectomy and systemic therapy, and then in that cohort. So the SEER database from 2001 to 14, including over 850 patients with non-clear cell RCC, reported by Marcioni and colleagues in European Urology Focus. And their conclusion was the cytoreductive nephrectomy had a 2-year mortality rate of about 52% in comparison to 78% in the group that did not receive cytoreductive nephrectomy. So cytoreductive nephrectomy still has a role even in the non-clear cell group. The IMDC database with 350 plus patients with synchronous papillary metastatic RCC treated with targeted therapy with or without cytoreductive nephrectomy and reported by Graham and colleague in European Urology Oncology in 2019 again showed that the median overall survival advantage in the cytoreductive nephrectomy group of 16.3 months versus 8.6 months. So underscoring the importance of cytoreductive nephrectomy even in the non-RCC. One of the factor that is even the West is feeling, but obviously this is much more important in our part of the world because of lack of insurance and the government support for use of these agents, is that it is expensive treatment. So if you look at the cancer-related spending in 2008 in the United States, it is 156 billion, which is twice the GDP of Sri Lanka and one half the GDP of Pakistan. The greatest contribution of this cost is medical supplies and non-physician services, including antineoplastic agents. So these newer generation agents are extremely expensive, and we need to keep this in mind, particularly in our part of the world. The per cycle cost of nivolumab and ipilimumab in the report by Chen and colleague in American Journal of Clinical Oncology last year showed that it is about over $20,000. Similarly, the combination of exitinib and pembrolizumab is estimated to be about $27,000. The advantage of cytoreductive nephrectomy is that it can defer further systemic treatment. So the treatment-free survival rates at 1 year being in about 2/3 of the patients who had cytoreductive nephrectomy and were not followed up with further systemic therapy. On a monthly basis, the cost of managing complication is also significant. So about $2,000 to $3,000 for the Nivo-EP combination and over $3,000 to $5,000 of exitinib and pembrolizumab combination. So not only they're expensive to administer, but also obviously they're associated with some complications, and their management adds additional cost. So in summary, the role of cytoreductive nephrectomy has evolved over the past few decades. The Cytocake, Nordic, Sun, and the Prof trials will probably shed more light on the role and timing of cytoreductive nephrectomy in the era of immuno-oncology. Due to the cost of immunotherapeutic agents, cytoreductive nephrectomy may be able to reduce overall treatment cost by allowing for a therapeutic holiday for patients who have had a cytoreductive nephrectomy. So the nephrectomy plays an important role in specific patient population, and the 4 groups that can really benefit from cytoreductive nephrectomy is those who have low volume, favorable risk metastatic RCC, those who do not require urgent systemic therapy, cytoreductive nephrectomy, followed by active surveillance. So they can have surgery and then they can be on active surveillance because their systemic metastatic load is insignificant or small. Patients with favorable risk or intermediate risk metastatic RCC who respond to systemic therapy with stable or regressive disease may consider delayed cytoreductive nephrectomy. In the end, patients who have had been offered with cytoreductive nephrectomy can improve their systemic symptomatic metastatic RCC and improve the quality of life. Thank you very much for your attention.